Hello and welcome friends. Today is the second talk in the resident series of the ACNS webinar of the month of August. The topic for today's webinar is craniosynostosis. To take us through the technical nuances involved in the planning and management of this unique congenital anomaly, we have invited two specialist neurosurgeons who are actively involved in the treatment of this condition. May I please introduce the speaker and the chair for today's webinar. The lead speaker of today is Prof Azmi Alias from the prestigious Tunku Abdul Rahman Neuroscience Institute, popularly known as the ICTAR in Kuala Lumpur, Malaysia. Professor Azmi Alias is a man known to wear many hats. He was the previous General Secretary of the ACNS. He is the Vice President of the Asia Australasian Society of Neurological Sciences. He is also the present coordinating editor of the Asian Journal of Neurosurgery. He has been instrumental in the educational activities for the residents and the young neurosurgeons, not only in Asia, but all around the world. The chair for today is Professor Kazuaki Shimoji from the prestigious Juntendo University, Tokyo, Japan. Professor Shimoji is an active member of the International Society of Pediatric Neurosurgery and is an active researcher in the field of craniosynostosis. On behalf of the Education Committee and the President, Professor Yoko Kato, I welcome Professor Azmi and Professor Shimoji to this online platform of ACNS webinars. I welcome my dear friend and co-host for today's webinar, Dr. Liu Bun Sen from Malaysia. Now, may I please request Professor Azmi Alias to start his webinar talk.
So this is actually Hospital Kuala Lumpur, located about 3 kilometers from the world famous Twin Tower. So lower down here, this is our Neuroscience Institute, Tunku Abdul Rahman. So it was founded on 20th April 1970, means this year we celebrate the 50th anniversary of the establishment. So most of the work that I'm going to share with you for the past, I think about 12 years experience, are mainly done in this hospital. But we have a new hospital that we just moved in about 1 year ago. This is our Women Children Hospital, also known as Hospital Tunku Aziza. And we have our dedicated operation theater, and we have a dedicated neuroscience ward. Okay, and this is, we received actually Professor Yamamoto last year to give a talk about epilepsy. So he managed to visit her and share his experience. So most of my experience in this institute, I will divide into 3 phases. The early phase between 2006 to 2010, when I started this craniofacial surgery together with the plastic surgeon. But in 2010, the most senior plastic surgeon resigned, so we stopped. We don't do any surgery. Then we restructured back our system in phase 2, where we started to do more cases. Because in Malaysia, it's very difficult to have a patient with craniosynostosis, mainly because of the perception by the public, parents, as well as pediatrician, that craniosynostosis is more of aesthetic surgery rather than functional. And then in 2010 and 20 forward, then we move into our phase 3. If you can see here, the numbers significantly double, and we do an average about 10 to 13 cases per year, and until starting from 2012 until 2019. So if you look at the numbers also in the first 6 years that I started this surgery together with my colleague, so majority of the cases that we have are predominantly syndromic craniosynostosis, such as Cruzon and Eppert. So we only have 1 or 2 non-syndromic single switcher stenosis like plagiokefali and trigono kefali. But with a lot of effort, especially when we try to educate the physician and public, as well as we expand our collaboration with other specialty, including genetic, and you can see the numbers tremendously increase from 14 to 43 just within 2 years. But the syndromic case remain predominantly more of the cases. And through this presentation, most of the work is a combined work with our consultant plastic surgeon, Dr. Muhammad Ali, and this is my 2 trainees, and our young neurosurgeon, Dr. Faishan and White Peng. And this is a picture that we take in our recent workshop. And now with 2020 and forward, so we move to phase 3, where we expand our surgery initially from traditional frontal orbital advancement, cranial wall reshaping, and we move to distraction osteogenesis with the contribution from the maxillofacial team. So we had a regular multidisciplinary meeting for selected cases. So I will go through with a couple of clinical cases before I go into deep about what make the decision that I do in terms of surgical management for craniosynostosis. So this is a child at the age of 3 months was referred to me with a multiple anomalies. You can see from the CT 3D reconstruction, multiple copper beaten appearance. He had maxillary hypoplasia, and then you can see there is a protrusion of the orbit. But unfortunately, the child also had multiple congenital anomalies, including cardiac, that which is not fit for surgery. So, but you can see within 2 months when dilated. But because of a lot of contraindication towards surgery, so we decided not to do any surgery, and eventually the child succumbed to death due to the natural causes. So we got cases which are very severe at the beginning for us to treat. So we have to be very selective. So this is also among a few cases that we have a complication that I would like to share that make we change our management and decision that also important in planning of surgery. This happened about, I think, almost 12 years ago. So a 4-year-old Apert syndrome. Actually, the mom is from Vietnam, married to a local Chinese Malaysian. So he was referred to me with history of a delayed milestone. She was not able to talk, so just able to make few non-specific words. She had a frequent history of URTI and nasal congestion. And then if you can see from the 3D reconstruction, all cranial suture are fused except the posterior part of the sagittal suture, and the frontal are still open. Despite that, the brain are bulged. So we decided to do cranial expansion surgery. In our center, initially we only do frontal beta advancement and cranial vault reshaping because most of the cases are syndromic. So we decided to put the patient under. So in our center, we divided our case into 2 phases. The first, when we open the scalp, the plastic team will go in. And then once we open the bone, the neurosurgeon will take over and we handle the part of it. As you can see here, so as we open the scalp, there are a lot of bleeding from overlying surface of the brain. So if you can see, there was a torrential bleed from the overlying of the bone. And during the dissection, we have a lot of massive blood loss. In fact, the child developed asystole on table, and we have to stop the surgery. We have to do CPR, and then we wait for a while. We bring back the scalp down, and then once we have blood ready, and we thought the condition was quite stable, and we decided to proceed with the elevation of the bone. And then unfortunately, it bleed again. If you can see here, we managed to take a picture during the procedure where you can see a torrential bleed from the diplo. It's not only from the diplo, but also from the sagittal sinus, from the emissary vein. So the child developed another episode of asystole. Then we have to stop the surgery again, and we second CPR on table, and then we wait for a while, and then we stabilize the patient. Then we make a decision that should we abandon the procedure or should we continue. So this is among the first few cases of Apert syndrome that we had 12 years ago. And then for some reason, we think that the patient is stable. So we went and proceed with the frontal betabar elevation as well as removal of the frontal bone. But it doesn't stop that. The patient developed myelin swelling, and he required inotrope support. And we decided that we should stop because it's already involved life of the patient. So we keep the bone bank, we keep the bone flat in the bone bank. We have a bone bank, keep at minus 30 degrees. So then we sedate the patient. We continue cerebral protection for overnight. On day 2, we repeat the CT scan. As you can see here, so there was a frontal contusion on the right side. So the brain is a bit tight. You can see the vessel system are obliterated. So you can see here, the frontal orbital bars are very thick and diplo are very engorged. This is where the source of the bleeding. You can see a very clear demarcation of the underlying of the bone that due to the chronic raising intracranial pressure, that eroding the undersurface of the bone. So we go in, we do craniotomy, we evacuate the clot after correction of coagulation profile. and then we sedate the patient again. As you can see here, the brain are much more relaxed on day 4, and then we decided to go in again because the bone flap are sterile. That we managed to fix back. We complete the cranial wall reshaping, and you can see here we fix it using a combination of non-resolvable suture, and here also we use actually wires in the early part of our practice. And part of the contused brain, we evacuate the clot and we do fascioduraplasty. Okay, and to our surprise, at day 10, the child stand up. Okay, we thought we already lost the child. This is 6 weeks after surgery. She came back to the clinic. She was more interactive. She started to speak a few words, and even she started to sing. This is just only within 6 weeks, despite all the hassle that we had. And a child more active, and then less URTI. And then 5 years later, she become more intelligent. In fact, she attended normal preschool. And you can see here, Appert, known to have syndactyly, and the plastic team already did the release, and she can even draw and writing. So this shows that craniosynostosis, if you do surgery, so there will be a lot of improvement in terms of developmental milestone. And craniosynostosis surgery is not simple. They are associated with many complications, as I demonstrated just now. Hemorrhage is one of the main problems, especially if you do it late. So this child presented at 4 years old. So we always have a late presentation in the beginning. So one of the way that to prevent it, if you can do early. So what is a craniosynostosis? Craniosynostosis is a craniofacial malformation in which one or more sutures of the cranial vault are fused prematurely. And we know that the normal skull of the newborn consists of 6 sutures, which are metopic, 2 coronal, sagittal, and 2 lambdoid. And the cranial bones, embryologically, the cranial bones form during the first week of fetal life through the membranous ossification of the mesenchyme, which arising from the dermal mesenchyme, which is from the scalp, which is a periosteum, and also the above meninges. And the sutures ossification usually start at 8 years old, and the bone union occurs at the age of 20 years old. And most of the brain will grow in the first year, and we know that there is a segmental growth between 0 to 5 years old, 5 to 10, and to 15. And by the age of 5 years old, the brain size already reached 90% of the adult volume. That's why it is so important that we want to do surgery, you must do during the first year. And if you do anything more than 5 years, most likely most of the damage or chronic rest intracranial pressure and developmental abnormality may not be reversed. And Virchow's law saying that the growth of the skull restricted perpendicular to the plane to the suture. So when you have premature fusion of the suture, instead of growing perpendicular, it goes parallel to the sutures. In trigono kefali, you can see a metopic sutures are fused, so that's why the bone are growing forward. You can have a pointed tip for head, and there will be a reduced volume of the anterior neurocranial fossa. When you have a scaphocephalus, you two sutures, sagittal sutures stenosis, you can have a parallel growth that you can have elongated head. And unicoronal synostosis, you can see here, fusion of the unilateral coronal suture. There will be a compensatory bossing on the opposite side. And you can see the growing of the bone, frontal bone are restricted on the ipsilateral side. And when you have a bicoronal suture state, if you have a lambdoid craniosynostosis, when you have posterior plagiocephaly, you can see here, this is reversed to anterior plagiocephaly. Okay, when you have 2 coronal suture stenosis, you call it brachycephaly. Okay, this is one example of the case. So by classification, you can have a simple, complex, and syndromic craniosynostosis. The syndromic are usually associated with sun abnormality, especially FGFR2 in Appert, Cruzon, Menke, Pfeiffer, and Jackson-Weiss, as you can see in the slide. And they have a certain characteristic of other body abnormalities. For example, like Appert, they have a typical mid-face hypoplasia syndactyly. This is Appert with a syndactyly. This is a crouson with a family history. Mother was a crouson, had a 17 surgery. This is a twin. We have a crouson also. This is a monkey. So we can also divide it into primary, secondary, or syndromic. As we know that most of the craniosynostosis, especially in the syndromic, there will be associated raised intracranial pressure. And then there are many factors that contribute, not only due to the stenosis, but also there are alterations in the CSF dynamic. There will be a hypoplasia cranial foramina that gives rise to venous outflow obstruction. Then mid-phase hypoplasia can also cause impaired respiratory that also eventually raise intracranial pressure. If you can see, this is one of our Eppert syndrome, overcrowding at the posterior part, and you can see a copper beaten appearance. So most of the time, because of the raised intracranial pressure, there will be a recession to the brain growth, and there will be associated abnormal cognitive function. And syndromic child, especially Eppert syndrome, are associated with mental retardation. And of course, with the abnormal face, they will have a psychosocial impact, especially when they go to school. So because of the craniosynostosis, not only the raised intracranial pressure, you can see there is an obliteration of the venous drainage of the inner system. That's why there will be a diversion of the venous flow. Instead of going to the system, they will be diverted to the emissary vein, and they go to the superficial scalp vein. That's why in the first case that I show you, even when you elevate the scalp, there will be a lot of torrential bleed. In fact, the diplo are converted into high pressure venous system. That's why it's very important when you cut the bone, you must make sure that you obliterate with the bone wax and so on, because there will be a lot of bleeding from the diplo itself. There are other associated anomalies in the craniofacial syndrome, especially in the brain. That's why before surgery, you need a very good imaging, CT scan and MRI, to exclude any other intrinsic brain anomalies. There are also associated ocular anomalies like exotropia, strabismus, amblyopia, especially those with plagiokefali. Now the indication of surgery mainly to address the raised intracranial pressure, because there will be a chronic intracranial pressure that inhibit the growth of the brain. At the same time, you want to preserve the cognitive function and the development of the child. You want to preserve the visual function, because there will be a shallow cavity that will give rise to raised intraocular pressure. Then some of the patient may develop progressive blindness. So by doing a surgery, you may prevent this. If you don't do early, there will be a progression of the facial deformity, and of course, a cosmetic intact. So there are the reason for you to do the early surgery because of the segmental growth of brain, as mentioned earlier. If you do it late, it's already irreversible, and it is advisable to do less than 1 year old, because the osseous defect undergo reossification, more complex before that. And if you do more than 9 to 12 months, there will be a progressive deformity at the skull base as well as the face. So you can do various type of surgery that you can do early. For example, strip craniotomy, endoscopic. You can do 6 to 3 years old. But in our center, we prefer to do most of the cases less than 1 year old. So the objective of the surgery is to overcome 3-dimensional growth restriction, and at the same time to correct the deformity. So the advantage of cranial vault reshaping, you can immediately correct the shape, but it is more extensive surgery. You can be associated with more blood loss if you're not careful enough, and associated with longer hospital stay. There are people that advocate that you can do open or endoscopic assisted technique suturectomy, but suturectomy by removing of the suture, unfortunately, could not address the issue of 3-dimensional volume restriction in the brain. So I think most of the cases in our center, we only focus on frontal orbital advancement or selective CVR for certain cases. We have not much experience on distraction osteogenesis, but in our center, we're going to start soon. So this is the reconstruction that we do by our maxillofacial. In our center, we do intracranial vault and reconstruction expansion early in infancy. And if they have a mid-phase hypoplasia, we prefer to do tracheostomy first. And as they grow later, then we do mid-phase advancement. Okay, so that is our strategy in our hospital. So this is one example of Cruzon that presented at month. He was referred to us at 3 months old with upper airway obstruction, tracheostomy done. Then we do a cranial vault reshaping frontal orbital advancement. This is 2 years later. Even with a tracheostomy, the child still can run and participate in the school activities. And this is, he attended normal school. And this is among the cases that we will plan for mid-phase advancement using a distraction osteogenesis in our phase 3. So I go through some of the cases. You can see here, this is a pancreastosis. I will show you how we do frontal orbital advancement in our setup. You have both coronal suture stenos, sagittal suture, metopic suture stenos, but you can see the lambda suture are intact, a very significant copper beta appearance. You can see a proptosis and frontal bossing, a little bit of pointed tip head. So this is from lateral view. Okay, you can see the inner table of the skull being eroded by the raised intracranial pressure. Okay, so we put under GA and we do a bicornular incision, and then we do subperiosteal dissection down to the orbit. And you can see this is our bicornular incision. So we do above the mid-ear and cross to the opposite side. And now, nowadays, when we address the emissary vein very rapidly, so you can see here most of it covered by bone wax. And sometimes it's quite important that you can control the bleeding from the emissary vein by using a wet gauze. You can pack it as you dissect along. This will help to reduce, to eliminate the torrential bleed and what we can see in our first series I mentioned to you earlier. So once you open, okay, you can see here, then this is drawn by the plastic team. So we draw the frontal orbital bar, so about 1 to 2 centimeters above it. So we do osteostomy to release the supraorbital nerve. Okay, so first we do bifrontal bone. We remove the bone first and then followed by frontal orbital bar. So the idea is to have a vertical expansion, horizontal, AP and lateral. So this is our instrument that we use. We use a combination of high-speed drill and osteotome. And then sometimes we have to use chisel to release the frontal orbital bar. So once we have released the bar, we give the bone to the plastic team. So you can see plastic team working on the bone. And the neurosurgeon will repair, for example, if there is a dura defect, CSF leak after the elevation. So then this will shorten the time of the surgery. Last time we used to do one after another. So we use the modification of macaque hernia frontal orbital bar, you can see here. So, and we also do pi craniectomy for our cranial vault reshaping. So for selected cases, we can have a complete resection of the pi, but in case of syndromic or there will be a severe addition between the bone and the dura, usually we do not advocate to have a complete re-excision of the bar like that. And we do segmental. Otherwise, sometimes we may end up with tearing the dura. So, and the supraorbital bar extended laterally downwards to the frontal nasal junction, and then it goes down to the upper part of the supraorbital, and then lateral orbital wall beyond the zygomatic frontal suture, lateral to the squamous temporal bone. And this is a part of the supraorbital bandu with the lateral tongue in groove. So this is one example of the trigono kefali. So you can see here, this is a frontal orbital bar, and then this is a frontal bone. And you can see that in the normal coronal suture, we will cut, we try to preserve the coronal suture, and the cut that we make either in front or behind the coronal suture, because it's quite important to preserve the normal sutures. Okay, in the early part, we use wires, but we start to abandon it about almost more than 7 years ago, because wires tend to be palpable and sometimes it can cause protrusion. So nowadays we use non-resorbable suture nylon. So this is the view. So you can see a neurosurgeon work from below and the plastic surgeon work from above. So during the elevation of the frontal orbital bar, it's quite important that you need to protect the underlying brain, because you can see here we use craniotome. So this is oscillating saw. So angulated oscillating saw, so that we do undercut on the superior roof of the orbit. And quite important for the assistant not to over retract, because there is an orbit below that. So that can cause further damage to the globe. So you have to work in synchronized manner. So you can see here, we usually make undercut on the roof of the orbit, and the neurosurgeon guide it from below. So you need two suction system, two light, so that both can work independently. So various type of oscillating saw that we use for different type, and sometimes the oscillating saw could not reach to the surface of the bone. Then we complete it with osteotome, as you can see here. All right. So in some cases, like I mentioned to you, so after we release the frontal betabar, we release the frontal bone, and then we do craniectomy, pie craniectomy. The suture, we cut it just or at the lamb dot suture at the back, and then later we will out fracture the temporoparietal bone. They will create an expansion on the lateral as well as a vertical volume of the cranium. Okay, this is another example. Okay, just to show you some example. If you can see the previous case, immediately once we release the frontal bone, you can see the brain is herniating up because it was really under pressure. You can see herniating up. So usually when the brain herniating up, we will do the lateral suturectomy first. We do craniectomy along this line. So we do lateral, we outfracture this temporoparietal bone so that you create more space. Then the frontal lobe can be relaxed. Then only we do, we release the bar. If the brain are relaxed, we straight away release the bar after we open the bifrontal bone. So this is what you can see following the excision of the part of the bone, and then bifrontal and the frontal betabar. So you can see here, we do a very wide excision so that this is to allow a space for the brain to grow. And the edges like this is actually before we close, we will trim it so that it become more rounded. Okay, we use a combination of non-resolvable suture here around that. So this is a lateral view. And then we advance it about 1 to 1.5 centimeter. So post-op child will be managed in ICU, okay, as you can see here. And then it's quite common to have facial swelling that we have to advise to the parents not to be worried. Usually it will subside within 7 days. So this is 5 days after surgery, and this is 7 days. And then you can see there was a lot of significant improvement. And the child cosmetically looks more rounded in terms of the head shape, less URTI, and improve cognitive function even we follow up the child after a few years. This is an example of the cases that we show. And then the initial part, we are not so sure whether how does the bone react. So you can see here, 6 months post FOA and CVR, we do a routine 3D reconstruction for the early part of the cases. You can see despite we remove a lot of bone, craniectomy, and new bone formation form from the edges of the bone, as well as island of bone form. Actually, it's from the osteoprogenital cells can be arising from the periosteum, as well as a dura that will eventually coalesce, and the brain will be, with the dissension of the brain, it will eventually shape the skull. As you can see, pre and post-op, and the copper beaten are much less. You can see island of bone, then eventually it will fuse and the brain will reshape back the skull. So you can see for syndromic cases, the ability to form a new bone are very tremendous. Despite a big gap, you can see it's fill up very fast within 1 year. At this moment, we have never done any redo for surgery, but we have cases where there was incomplete frontal orbital bar because we have to abandon the procedure due to bleeding. So the rest of the cases at this moment, we have never done redo because of the refusion. The frontal orbital bar are important. because you can release the stenosis sutures immediately. You can decompress cranial vault. You can reshape frontal bone, especially for plagiocephaly, trigonocephaly, and as well as improve shallow orbit, and it's also important for the globe protection. This is just another example pictures of another cases, and we use capillary silicone drainage in front and at the back that we keep about 7 to 10 days after surgery. So just another cases, and you see pre and post-op. Okay, we did small studies to show how much that we can create in terms of volume. So we published recently. So we measure the intracranial volume pre and post-op using a 3D CT imaging computer-based, and involving 14 cases with average age about 23 months. So involves 7 syndromic and 7 non-syndromic. And then the finding that we found that the mean preoperative intracranial volume compared to post-operative, there was significant increase, about 22%. And then for syndromic, the increment are much more compared to non-syndromic. Okay, so this indicate that FOA and CVR really create the expansion and space. And almost all, 100% of cases shows improvement in the corpus beaten appearance. So this is another case example of trigonocephaly. So you can see this is metopic suture stenosis. Okay, all other sutures are intact. So trigonocephaly are usually also associated with many other abnormality. Ethmoidal hypoplasia, supraorbital retrusion, the angulated lateral canthus at the back, and because of the pointing like that, there will be hypothyroidism. In other words, the distance between mid-papillary are become nearer. Okay, and then the cephalic index on the bitemporal are shortening and the bifrontal are widening. So this is not just a simple suture problem. It also involves many other problems. That's why suturectomy for us, I think it doesn't work, because you have to really address more than that. So this is, we put the patient under, we do bifrontal orbital bar, you can see here. And then we also do bifrontal craniotomy. But in this case, we don't do the cranial board reshaping on the frontal occipital area. So this is after elevation. So you can see here, wedge osteostomy was done at 2 angles. So in the middle, so and at the end. So eventually they will reinforce with a non-resolvable suture. Sometimes in order for you to make it, to keep in a position, sometimes you can put a bone here so that it will widely open. So this is as a construction for trigonal. This is not for trigonocephaly actually. So this is another cases, but for trigonocephaly, so we also cut the suture on the metopic, and then we fix the frontal betabar. So post-op, you can see significant changes, not only in terms of cosmetic, but also the bone shape. So scaphocephaly, so we also use pie cranectomy, but we don't do frontal betabar elevation. You can see the changes pre-op 6 months and after 2 years. So plagiocephaly are much more complex, because you have to address the problem with the shallow orbit, and you have to address the problem with the deformity and unequal frontal bone. You can see right compared to the left. So you can see from the CT 3D reconstruction, there is a left coronal suture stenosis, but the other sutures are intact. Okay. So plagiocephaly are associated with many other abnormality, like uneven orbital rim. They resulted in orbital dystopia, and there will be compensatory frontal bossing and flattening of ipsilateral frontal bone and the orbital rim, as you can see from this. Then that also associated with skull base deformity down there. Okay, so you can see clearly this is ipsilateral coronal suture stenosis. Okay, for plagiocephaly, we do bifrontal craniotomy, like here, and then we do frontal betabar, and then we do reposition. This is designed by our plastic team. We bring the bone from the contralateral parieto-occipital area forward, and whereas the frontal flattened area we bring backward. So if you can see like that, okay. So once we remove this bone, so we reposition it on the opposite side, okay. And the previous left bone, we put it on the left side, and the front we do a frontal orbital advancement on the flattened side, which is on the affected area. So this is actually left frontal bone. This is actually right parieto-occipital bone. So we do reposition it on the opposite side. Okay, so you can see here. This is a 3D reconstruction of one of the cases that before and after. In this, actually, we do an island of bone that we transposition to the opposite side. So post-op cases with plagiokefali. Posterior trigono kefali, you can see here, posterior sagittal sinus and 2 lambdoid suture stenosis. And you can see the occipital bone are also growing into the posterior fossa. As you can see here, some of the bony ridge actually compress. Sometimes it causes further occlusion at the foramen magnum. So this is quite important that you need sometimes to release downward. It's not only posterior void reshaping. Sometimes you have to remove the pointed tip that cause compression at the cervical junction. So we put the child in prone position, similarly by coronary incision, and we remove, this is actually free floating parieto-occipital technique. So we do strip craniectomy on certain part, but we leave part of the bone floating there. So we need that for us to attach it to the bone that we remove, and we do a barrel stuff here. You cut like that, like shell, and then we fix it loosely with a non-resorbable suture. So sometimes craniosynostosis, for example, like syndromic, they are also associated with craniocervical abnormality. For example, tonsillar herniation. So you need to make sure that you have a proper imaging, for example, like MRI, because during the positioning of the patient, this may cause trouble to the patient. So ventricular emboli is quite common. For example, in Cruzon, up to 70%, and in Eppert, 70%. If you have hydrocephalus, in this, for example, like in scaphocephaly, we will put a shunt first. So this will help to reduce the raised intracranial pressure. And then once the child is more comfortable and the symptom less, then we plan the surgery, cranial board reshaping. Okay, I will show you some of the cases with pancreastosis. You can see patient like bicoronal suture stenosis, sagittal suture, lambda suture stenosis, and the patient also have Chiari malformation and hydrocephalus. So for this case, we treat the hydrocephalus first, because the hydrocephalus, the Chiari could be secondary to hydrocephalus. So by releasing the pressure by doing a shunt, we hope sometimes the Chiari can be reversed. But in this case, this is a Chiari 2. So it's unlikely to be reversed, but we do a shunt first and followed by a posterior cranial board expansion. So this is another case of 3 years old. So you can see here, we position the patient in prone, horseshoe, and then you can see the shunt at the back. So in this case, we need to do a 2 separate incision. So because we need to decompress the foramen magnum, because there was overlying the overgrowth of the bone that caused impingement on the craniocervical junction. So first, we raise the flap. So you can see here, then we raise the pericranial flap. We keep the shunt inside too, and then we raise the bone flap and maintain the shunt floating on the surface, as you can see here. All right, and then we make another incision. We do a suboccipital craniectomy, and then sometimes we need to use a microscope for certain case. And we have 3 cases like this. One of the cases that we have to put a microscope for that we can carefully drill the bony spike that engross into the craniocervical junction. For this case, actually, for this particular case, we do not need microscope because it's quite obvious that we can cut osteotomy. Then you can see we connect, we remove the bone down to foramen magnum, and then we do a barrel shape reconstruction at the back. Okay, so then we close it. So now, now we have, we move to another more complicated cases to the phase 3. So we are about to do our mid-phase advancement, but our experience limited by many factors, because in order to do mid-phase advancement, we need distractor, and distractor are very expensive in our country. So we have to create fund in order to get the instrument. So this is a case that we plan to do mid-phase advancement. It was supposed to be done this year, but unfortunately because of COVID, so we have to postpone it to later date. So we do a 3D printing. So the maxillofacial team start to simulate and to measure how much that distraction will be done. So hopefully when things goes back to normal, then we will proceed with our construction. So I think this is my last few slides. From our experience, we realized that the craniosynostosis surgery is not purely about aesthetic. We need to give a room. We need to protect the brain from the severe compression by the intracranial pressure, so that hopefully that the brain can grow well, and then that also can hopefully can prevent from mental retardation. We need a multidisciplinary team approach. As you can see, that's only neurosurgeon, plastic surgeon. We need a good pediatrician, maxillofacial, pediatric respiratory intensivist, and many others support team, anesthesiology, blood bank, so that because this procedure is very complex and associated with several complications if you're not careful enough. And there is no one technique that suits for every patient. So whatever surgical approach that we need to do must be tailored to the individual need. And from the experience that we learn, we do, the cases are more earlier, because if you do late, then we have a more problem like the case that I showed earlier. So we also work together with the parent support group, because nowadays patients also not only want to know what type of treatment they're available, they also want to share their experience and educate the public, so that those who have craniosynostosis, either syndromic or non-syndromic, will come forward for treatment. So this is their motto: a child with special need will inspire you to be a special kind of person. So that's my end of presentation. Thank you very much.
Thank you very much, Professor Azmi. It was a wonderful presentation. We are so delighted to have watched so complex videos outlining the various steps of such complex disease like craniosynostosis. Thank you very much. Now, may I please invite our chair, Professor Kazuaki Shimoji, to say his expert comments.
Okay. Thank you, Professor Alias, for the great presentation. So in the first part of your talk, I recognize that we are not the only one who had a nightmare. So everyone has a nightmare doing this craniosynostosis. The main reason, well, I also agree that it is not only for aesthetic issues. We do need to do surgery early enough to improve the cognitive function and development. And I have a couple of questions. And in your plagiocephaly cases, you only, it was really interesting to remove the backbone to the other side.
Yes.
And in our institute, the plastic surgeons just turn around the frontal bone to exchange the bossing part and the flat part. And then we advance the orbital bar. I didn't see the procedure you moving the orbital bar front to the front in the plagio cases. But it seems the aesthetic results are very good. What do you think about, do you need to move the frontal bar a little bit advanced to improve this frontal skull base?
Yeah, thank you for your important question. I apologize that I do not show the the part that you're concerned. Yes, we do bifrontal craniotomy,
Okay. Mm-hmm.
and then we do frontal orbital bar,
Mm-hmm.
and then the ipsilateral set which are affected, and we advance it about 1 to 1.5 centimeter
Okay.
forward.
Mm-hmm. Mm-hmm.
So, but
Okay.
the site which are not affected, we keep it
Mm-hmm.
at the same position.
I see.
Yes,
I
we
see.
do
Okay.
advancement on the opposite
Mhm.
side, on
Okay.
the affected side. Yes.
And also the other question is, if you do the shunt first, which do you prefer? You do a posterior puncture or the puncture from the anterior horn?
Oh, okay. So we get used to put at the back for several reasons, because we have a burr hole type of valve. In children, usually is quite prominent in front. So it's quite nice to put behind. So, but for selected cases, for example, like craniosynostosis, we prefer to put programmable shunt.
Okay.
A programmable shunt with side valve, not the burr hole type, on the parietal occipital. And we wait for a while, then we repeat both imaging as well as we go by clinical. And then once the part of the component of hydrocephalus has been addressed, then only we plan for the proper stage of surgery. Yeah,
I see. So we prefer posterior puncture because we don't want to go too crossing of the cranial suturing with the shunt. And also I tell our residents to do not see the shunt, do not, expose the shunt itself, put the tissues above. And also, my last question is, I also agree to do foramen magnum decompression in the chronic tonsillar herniation cases. In our institute, we think that we are possible to do in a one incision. If you expand the high coronal incision all the way down, and we put craniotomy in the posterior fossa, and then we do barrel stave osteotomies, and then you can go all the way down to the foramen magnum using a microscope. So maybe that could be another point to avoid two incisions.
We had 3 cases. 2 we just do from the bicoronal. We can reach that. But the one that I do one incision, because there are severe formation of the bone that grow inward and really down. I think quite close to C1. Then we try to use microscope from above, but we cannot get a good angle. So we make a second incision.
That's I think it's agree. I agree with that too. Thank you very much for a great presentation.
Thank you, Professor Shimoji, for your expert comments. In line with the question that Professor Shimoji asked, I would like to ask Professor Alias that what kind of shunt do you use? Is it a programmable or a non-programmable shunt?
We use a programmable shunt, but the problem with programmable shunt in our institution, because it's a public hospital, free. So programmable shunt is very expensive. So if we have our stock, then we give it free. But sometimes we offer to the parents. If they can't afford, then we use a standard abrasion valve. But we prefer programmable shunt for craniosynostosis.
We'd like to open this platform for discussion for others as well. Professor Muthukumar, would you like to say something, sir?
Yeah, that was an excellent presentation, Dr. Azmi. I really enjoyed it. And
thank you.
Nice of you to start with a complicated case. And I saw in that particular case, the 3D reconstruction showed plenty of large emissary foramina. So I think not only the bleeding, but the intracranial swelling that happened during surgery was because these cases, as you rightly pointed out later in the lecture, the jugular foramen is stenosed. So most of the venous flow is through the emissary foramina. So when we wax it, these patients develop terrible swelling. And as Dr. Shimoji pointed out, we have also had burned our fingers on a couple of cases. We had to close. We didn't have the guts to proceed like you did. After the patient developed we resuscitated and closed and came back on another day. So there have been reports in the literature about this happening, that these emissary phenomena are very dangerous in craniosynostosis surgery.
Yeah.
And the next thing is about the barrel stave osteotomies, which Dr. Shimoji pointed out. One of the interesting things which I found in your intraoperative images that you showed, I think many of the intraoperative images did not have barrel stave osteotomies, whereas we use barrel stave osteotomies, especially in the temporal region, often. So, is there any specific reason why you avoid barrel stave osteotomies?
No, there is no specific reason, but we just somehow like the pie craniectomy, and then we out fracture the temporal parietal bone laterally. So by doing that, we get good lateral expansion. But you realize that at the end, as we move along, so now slowly for posterior, we like to do barrel stave. But for anterior craniosynostosis, we still prefer to use the pie craniectomy because the excision of the bone can go down behind until the lambdoid. So this is especially for pancreastosis. So we think that that will address not only anterior but also till the end. So that's why we prefer pie craniectomy. But yet we still follow up our cases. So we may change our strategy in future. But for posterior, yes, if you can see that we use it for posterior, we use barrel stave that you mentioned.
Dr. Shimoji, would you use barrel stave osteostomies?
Yes, we do. We do.
Yeah.
Our plastic surgeons love to chop the skull. So once they do the osteotomies, I hope there's no plastic surgeons here, but we cut it and they cut it and then they make a fracture. And that leads a lot of bleeding, which is a nightmare for the residents because they couldn't go to sleep at that night. So I would like to ask all of the attendees, but do you have any ideas how to avoid these nightmares after surgery? Because one of the experts in Europe says that if you don't have a complication in craniosynostosis, you're very lucky or you have less cases. Do you have any ideas how to avoid these bleeding problems? Because I really, really struggle dealing with bleeding during surgery and after surgery.
When I see a patient whose 3D CT shows a lot of prominent emissary phenomena, while counseling the parents itself, I tell them the risk of surgery is high. Yes. The risk is a little high because not every child can or will be resuscitated from a cardiac arrest. So that's a very difficult situation to get in. It's a nightmare which makes you lose your sleep for a few weeks at least.
Yeah.
And my question, one more question, if I may, Dr. Raja, if I may.
Sure, Professor.
You made a very nice point. Earlier, we also started using steel wires, and we have switched over to Prolene sutures because these wires have the tendency to protrude through the thin scalp of the children. So finally, for the single sutural synostosis, do you think in future, as in probably in the West, endoscopic craniectomy with reshaping by helmet will come to stay?
There are, I think some people have experience, but from my literature reading and to my understanding, this single suture stenosis is not just a single suture. The problem is also associated with skull base. Suturectomy, I think, will not address the three-dimensional volume restriction. Okay, it probably address the shape, but it does not address the volume expansion. So I still think I will not do that procedure. And on top of that, if you do endoscopic suturectomy, you also have to use helmet. Okay, when you use helmet therapy, you have to put the child 23 hours a day and for many months. So you do a minimal incision, so-called minimally invasive surgery, but you got a maximum invasive with the helmet for a long time. And the cost also, I think the helmet, we tried to do it before, but the cost of helmet also very expensive. And then you have to custom it to the patient, and the helmet also have to change from time to time. So we have no experience, but maybe works in, some people claim that it works, but I think it will not be able to address the issue of 3-dimensional volume and brain restriction I mentioned earlier.
Another practical issue which we may face in tropical countries like ours, like India and Malaysia, is that the
Sweating.
climate is so hot.
Yeah.
The children do not. It's a very serious matter. The children, because the children and the parents will not be compliant for wearing a helmet for 23 hours a day. That's not going to happen.
Agree.
That's a real practical problem, because we just cannot extrapolate the findings of the Western literature and apply it to our place.
Yeah.
That
So
is
just
true.
just to add on the bleeding. So after we have experience now, we have a strategy. Do it early, number one. Number two, when you release the scalp, so every time you expose the bone, we put abdominal pack wet with saline. Okay, whenever there's a bleeding from emissary vein, wax it. So that works. That's number two. Number three, when you cut the frontal betabar or front of the bone, so sometimes we do a perforator first so that we got good control. Then as you cut, then when there is a bleeding, we take a bone wax, we roll it like a roll, like a sausage, and we plug into the gap while you're completing your procedure to get a complete elevation. So that will help to stop bleeding from the emissary vein. And in another part is the anesthetist. We use tranexamic acid. So we found that those syndromic cases, we will prophylactically use tranexamic acid. And the anesthetist, I usually ask a question that, what is the 20% blood loss that you allow me to do? So we have to calculate the body weight. Then you must remember that you are operating on a small kids. So sometimes you cannot have the same attitude when you operate on an adult.
Yes.
So that also very helpful, and you have to communicate with your counterpart. So the boss in the theater is the anesthetist. If they say you better stop, then I stop. Because no point proceed, then we end up. That is what we learned from the first case. If you can see, I nicely show that the bone was barely open. We don't put anything. We just let it bleed, and we focus on the elevation of the bone, the reconstruction. We forget about the mechanism like you mentioned correctly. At that time, we don't even do an MRI to exclude, CV junction anomalies. So from that case, we stopped operating for 3 months. So we come back again, we discuss what went wrong, and then we make sure that next time we got a good anesthetist backup, we got good blood, and then we encourage patient to operate early. And in fact, we have a dedicated theater. We managed to block a dedicated theater just specific for craniosynostosis every 2 weeks of the month. So we fix it and we do it on Monday. So the first day of the week. So these are among the factors that I think nowadays, I would say in the last maybe 5 years, we never encountered problem with bleeding anymore. So this is among the strategies that we use after we had that experience.
Thank you. Thank you very much, Professor Muthukumar, Professor Shimoji, and Professor Azmi Alias for such nice points in the management. There are a couple of more questions which have been popped up on the chat. I would like to invite Professor Arunkumar Srivastav. Are you there?
Yeah, yes, sir.
Yeah, please, Dr. Arun.
Indeed, a very good presentation. I'm an additional professor neurosurgery at SGP Lucknow. And even I started doing craniosynostosis from last 6 to 7 years. Your first case was, luckily, we had a very good escape as a patient survived. But I really want to mention to all those, the young neurosurgeon who wants to do these kind of cases. And you very nicely, very honestly shared your experience of, 3 times CPR, and as Muthu sir also shared, that this is really a nightmare. So what I, gradually opted, like going stage in a single surgery. So as all of you were discussing, first and very important thing is infiltration. Obviously, xylocaine and adrenaline, whatever anesthetist has allowed you, you do that infiltration, but saline is something which is in your hand. You can infiltrate an amount of saline, which can give you a very good, hemostasis. Second thing, I only proceed once my anesthetist says, yes, go ahead. Then only I give the Gallial incision. And I'm not raising periosteum along with the main, incision. So I see in your cases like you used to elevate periosteum along with your incision. So keeping periosteum up to end and then taking out that periosteum as periosteum going to help in the reformation of the bone. So I'm kind of charring that periosteum with monopolar. That is also minimizing the blood loss in my cases. And third and very important thing is I am most of the time with pre-operative simulation and all, I'm raising the bone in pieces. So most of the time when you are raising bone over the sinus or you're trying to raise a big bone, as you are mentioning about the pie, pie shape of bone removal and placing it further, that is actually causing a lot of blood loss in and around the sinuses. So these are the point I want to mention from my end to the young neurosurgeon to avoid blood loss. Because if you see nightmares in your initial career, then probably you will not take it further. So that is what my humble, experience, whatever I gained over the years. Thank you so much.
Thank you, Professor Arunkumar, for coming here and supporting our educational initiative. There are a few more questions. Dr. Bobby Ipe is here. Dr. Bobby Ipe?
Hello.
Yeah, Bobby, please.
Hi, Dr. Raja. Excellent presentation, sir. Excellent presentation, Professor.
Thank
No,
you.
I just had one single question just to ask, will you be able to remove the programmable shunt once the ICP comes back to normal at a later part of the children's life?
So far, all the cases that we inserted, we have not or never removed it yet. We go by clinical. But in case if they have developed symptom of over drainage, so we may challenge the shunt first. For example, clamp first or ligate first. If the child okay, then only we remove. So, but in my series, we only have about maybe 5 or 6 cases with shunt, and none of it that we remove after the surgery yet. So we go by clinical. I have no idea if other speakers or other professors have other experience.
Yes, Dr. Shimoji, what would you like to comment?
Move the shunt after the craniosynostosis cases. If it's working, I just let it go.
Yeah.
I never tried to touch it.
Thank you. Thank you.
Right. My friend Liu, would you like to come in?
Hello, thanks Dr. Azmi for a nice presentation.
Hi, Leo.
Yeah, hi. So just want to find out what are the safest, in terms of decision making, how early a surgery should be performed. Either we are looking at the age, or we are looking at the symptom, or we are looking at the body weight. My second question is, when we look at the dilated scalp vein, would that help you to determine where you want to do your bicoronal incision? Whether you take that into consideration when you plan your coronal incision. Thank you.
Okay, a very good question. I answered the second one first. Of course, you like it or not, your incision will cross over the dilated vein. So most important thing during the dissection, not to cut directly, because it's an engorged vein, easy to identify. Use bipolar, cauterize it, then cut, rather than cut straight. So then we use, clip or Renis clip and so on to clamp the scalp. So that will help to eliminate the risk of bleeding from the scalp because you can see it. So the second question.
The decision when to operate.
Okay, timing.
Yeah, timing.
Okay. So if you look at literature, some even advocate, if possible, 6 kilo above. Okay, in terms of age, preferably less than 1 year old. But I would look at reason. The reason is because of torrential blood loss, the physiological response, okay, and then whether the child is symptomatic or not. So in the previous years, we quite difficult to convince the parents or even the pediatrician or genetician that the child needs surgery until they want to see the copper beaten, until they want to see the engorgement. This is already late sign. So those who syndromic, you operate early. Don't wait until all those signs develop, because I already show in the first case, when you wait for all those signs, you actually asking for disaster. because the deep flow bleeding, is a high pressure bleed. It's like arterial bleed, even though it is a bone. So operate early. In our experience now, the youngest we have operate about, I think, 5 to 6 months old. Okay, for syndromic. But again, for syndromic, they are more complex than just craniosynostosis. So sometimes we cannot do surgery early because they have a respiratory problem. Sometimes they have airways obstruction, and then they have many other issues need to be addressed. So in principle, 6 kilo above, less than 1 year old. So the earlier, the better.
Thank you. Thank you, Liu, for asking. That was a beautiful question. There is a question which has popped up. Do you feel that Prolin sutures does not fix the orbital band tightly enough, especially when the band has been split?
Our experience, the physician done by the plastic team, but they use a cross-locking kind of type. So it hold the bar. But you must remember that eventually there will be ossification and new bone formation. That will be permanently hold the frontal betabar in position. So for us, using the non-resorbable suture or even resorbable suture, as long as you hold it tightly on certain area, so there will be no issue at all. So we don't use plate, we don't use resorbable plate. Suture works in all our cases.
Dr. Azmi, this was specifically about when we split the orbit. When we split the band, sometimes when we fix it with Prolene and we then place the flap back, it appears as if the split makes the hypertelorism excessive. It tends to push the band back. And it also prevents the bone strut from being held tightly. So have you ever had that problem?
To my, I can't recall any cases with that problem. Probably is we fix not only at one angle, we fix several angles. So that hold the bar in position. It's not only one or two sutures. There are several sutures that hold it in position. So at this moment, we don't see much problem with that using the non-resorbable suture.
Thank you. Thank you for asking that. Dr. Mirna Sobana wants to ask one question.
Good evening.
Hi, Mirna.
Hi, Dr. Azmi. I would like to ask whether the zigzag incision is still used, or you prefer the usual linear incision for good outcome cosmetically after the surgery. Thanks.
We try to, because the incision usually made by our plastic surgeon, so they are happy with the just curvilinear incision. So at this moment, because it is done inside the hairline, so we don't see much problem. But of course, in the beginning, you can see the incision quite obvious. But as the hair grows, we at this moment only, I think one or two patients complain that they can see the scar. So, but I've seen many presentation, especially from Europe, they like to do the zigzag incision so that the hair can cross nicely. So we don't have experience on that. Probably 1 or 2 days later, we should try. What about you? You use a zigzag incision?
At first, I was trying to do zigzag or maybe just waving kind of incision. But after I talked to Professor Goodrich some time ago, he do the zigzag or waving incision. But right now, he only do the usual linear incision. So I go back to the usual linear incision because it's very easy to close the skin, and then it faster. So I go back to the usual incision.
Yes, Sachin wants to ask a question. Sachin.
Thank you very much, Professor Azmi Alias. It was a wonderful lecture. I know that you are a good endoscopic surgeon also. So do you have any experience on the endoscopic craniosynostosis repair? This is my first question. One more question about the helmets. Can you just mention a few points about the use of helmets in case of craniosynostosis management? And one more thing, there is we had Dr. Shimoji, he had come to India and he had spoken about the role of craniosynostosis surgery, especially the sphenoid ridge excision for the patient with the for the attention deficit hyperkinetic disorder. Maybe Professor Shibuji can talk about that. So those are my questions we can discuss.
Okay, I answered the first two questions. Answer is very simple. I don't have experience. Number one, in order for you to do endoscopic assisted suturectomy, you need a special endoscope. It is, I think, produced by stores. But of course, you can make a modification from your existing, because the stores endoscope, they have a special elevator so that you can elevate and you can put the scope beneath and you can make a recession. The excision actually using a scissor. So you can't do it if the skull is very thick. You can't put high-speed drill underneath. So you need to do it only in young patient. I think if you look at Jimenez paper, less than 5 to 6 months or even 3 months old, where you can use a mechanism bound or heavy scissor to cut it using a scissor. Okay, not using high-speed drill. So number two, helmet, we have discussed initially. We also actually wanted to try, but unfortunately it involved cost. And helmet is actually used for suturectomy alone. Suturectomy plus helmet. And then, like I mentioned earlier, you have to put the child 23 hours a day, and then it involves cost, and you have to change the helmet from time to time. So it is more hassle, and suturectomy plus helmet does not address the three-dimensional issues of gross restriction. So I personally think that both technique not work. I'm not so sure. Maybe other center or other speakers have experience. Maybe they could share their experience. But for me, both not in our practice, in our center.
What about in your place, Professor Shimoji?
Actually, I don't do endoscopic surgery. I asked one doctor to come into our institute to do the removal of the coronal suture synostosis in a cloverleaf skull, just to buy time to make the skull thick enough to do the posterior distraction. So I also don't have any experience. I think craniosynostosis cannot be cured only by the suturectomy because the skull base should be more focused. And so that is connected to Professor Chemat's question that I'm surprised. But that actually that Shimoji was the other Shimoji, which is my father.
Yes.
Yeah. But I also believe that the removal of the sphenoid ridge could release the pressure of the frontal lobe. We are doing this mild form of metopic suture synostosis surgeries to prove that we're doing something good, but we're still struggling to give results to convince the world. So we'll still do that work.
Yeah, thank you. Another question that I would like to ask you, you showed a few cases where you had Chiari, there was a tonsillar herniation. So, and you said that you would do a foramen magnum decompression. So in your follow-up, if you find that the pathology has not receded, would you still open the dura and resect the tonsil or leave it alone if the symptoms are persisting?
I may consider to open the dura and release it, but I will monitor with the MRI, especially when you have signal changes on the cord. So I don't wait until you have syringomyelia. So if patient symptomatic plus clinical deterioration or early changes on the cord, so I will advise for the parents that we go in to treat the Chiari. It could be other associated problem that cannot be addressed just by doing cranial posterior expansion surgery. So we need to address that in a separate surgery.
Thank you very much. But I think you never open the dura in the first instance.
Yes, you don't. We just remove the bone, that's it.
How is it in Japan, Professor?
I agree. I don't open the dura because we believe that if we move the skull behind to get more volume, it could release the pressure of the chronic tonsillar herniation. And if we see syringomyelia, I agree. Then go back to remove the bone again and remove the dura. That could be another idea.
Right. Thank you. Thank you very much. My good friend Satish is here. Satish, would you like to come in?
Hello. Yeah, it was a very nice presentation. I enjoyed a lot. There was a lot of important questions and doubts that was answered for young neurosurgeons. I have no specific questions. Thank you.
Thank you, Satish, for joining. Vignesh, my good friend Vignesh, are you here?
Yes. Hi, it was a great presentation. I mean, quite a bit of facts coming out of this and also personal experiences shared. I really don't have any specific questions. I believe most of it has been exhausted. Thank you.
Thank you, Vig, for coming in. I think there are no more questions. We have discussed everything in detail. So we'll wind up this session now. Thank you to the speaker and the chair. On behalf of the Education Committee and President Professor Yoko Kato, I thank you, Professor Azmi and Professor Shimoji, for coming here and sharing your valuable information with the young residents and neurosurgeons. We hope to have your support in the future editions of the ACNS webinars too. Until then, it is bye-bye from all of us.